Basically, this is how your software looks like when you are in, just 1 minute. Here, like this is the 6 map which you get when you open the MS39 map, which Dr. Vavikar and Divya ma'am has already spoken about. So you can actually just on the software, you can customize what all maps you want and what you want to see in the 6 maps, like tangential curvature, corneal thickness, epithelial thickness, stromal elevation, post elevation, anterior elevation. I'll just go straight to the point. The beauty of this machine, as both of them mentioned, is that it gives you the epithelial thickness. So when you have an epithelial thickness and also like epithelial thickness is given by other instruments also, but here what it does is it dissociates your epithelium and it gives you the true curvature at the stromal level. So if we have a myth that, everything starts at the posterior surface, but it is not the case. Like, you also have to look at your Bowman surface or stromal surface to see what the true elevation is. So what you see here is like, this is your tangential anterior curvature. This is how your epithelial thickness map is, anterior elevation, posterior elevation, and the added one here is stromal elevation. So just like what our topography looks like, green means it's even, blue means it's on the flatter side, and yellow means it's on the steeper side. So this is one case example where you can see that there is some inferior steepening present here, which correlates here with the stromal elevation. But here, epithelial thickness, a little bit of hyperplasia is there, which correlates.
Pooja, can you use your cursor, please?
I am using, sir.
But I don't think we are seeing the cursor.
Okay. 1 minute.
It's okay.
Now
if
can
you're
now can you see, sir?
No, I think we can't. But anyway, continue with it. Let's not waste time.
This one.
So did you share screen or share the you shared the entire screen, right?
Yeah. This one. Can I point it?
Doctor, what you can do is you can just stop your screen sharing.
Okay.
Then again, click on share screen button, and at the very left hand topmost corner, you will see screen. Just click on that.
Screen. Okay.
Yes, screen. Click on screen. Yeah.
Now you can see my cursor or still no?
Yeah, that's perfect. Perfect.
Okay.
Yeah.
Okay.
Thank you.
Okay. So here you can see that there is a little bit of inferior steepening present here, which is actually correlating with your epithelial thickness. So if you just see the tangential anterior curvature, you will think that this is an inferior steepening and you will avoid doing a refractive surgery on this patient, thinking that this is a suspicious case. But if you now correlate with the epithelial thickness, it actually coincides. Your epithelial hyperplasia coincides with your inferior steepening. But if you see the stromal elevation, actually the stroma is it's normal. The curvature is extremely regular. There is no stromal elevation present here, and also there is no anterior elevation present here. Post elevation, yes, it is there, but it's on the normal side. So this is what it tells us that whenever you have an inferior steepening and you are in doubt, you correlate your epithelial thickness changes, whether it's in the same area or not, and see the stromal elevation, whether it's present or not. And that is how we come to know that it's a normal surface or an abnormal surface. Now, this is one case. I'll just go to the other eye of the patient. Just give me 1 minute. I'll have to every time do this. So.
Dr. Pooja, are you facing problem in switching
No. Every time I change the scan, the software, I'll have to stop sharing. Don't worry.
All right.
Okay. So this is the other eye of the same patient. If you can see here, yes, again, there is an inferior steepening present here. But what Vavikar sir spoke about in his case, like O-shaped epithelium or a ring-shaped epithelium, which you see in keratoconic eyes. If you see here, then this epithelium has actually got a donut shape of an epithelium present here with a very small zone here. And if you correlate with the stroma, there is a little bit of bump present here. That means your stromal elevation is actually like it's evolving and it's in the evolution phase. So, would you like to?
Basically, what this case demonstrates is it demonstrates that one eye, if you just look at the one eye, it looks that there's a completely normal topography. But if you look at the other eye, there is an earlier sign of maybe an evolved or aborted ectasia. So look at the corneal thickness. It is 570, 580 microns. We shouldn't be worried if you have not looked at all this. But if I have to do a procedure for this patient, even if it's a -2, I would do a PRK on this because of this. If not for all this technological knowledge, we would have probably done a LASIK or SMILE or one of those procedures. Dr. Vavekar or Dr. Divya, would you want to say anything about this case? Because this is a representative case of why we need these kind of hybrid tomographers, because this picks up a very beautiful way of understanding the power of imaging everything in total.
Absolutely, sir. It's giving us an idea of everything. So each layer is like displayed. So as you said, even if it is a early ectasia or aborted ectasia, PRK would be the right procedure, as you rightly mentioned.
Dr. Pooja, can you go on to keratoconus screening and see pattern deviation in this patient?
Sure, sir. You can see the keratoconus map, sir?
Yeah, see now you know very well that epithelium pattern deviation is not there, but probably in stoma there is a very small area of pattern deviation, which confirms that it should not be dealing with doing LASIK, but it should be doing PR. Am I right?
And absolutely. That is, I mean, this is where see, many people tell me that, why should I buy a costly machine that is going to burn my pockets? I would say the opposite. If this was any other topographer, like any other conventional topographers, you would see an inferior stapling. What would you do? You would either do nothing, you would be scared that this is an keratoconus, or you would just send the patient off because not all of them would be suitable for ICL. Because if you understand the whole cornea in a holistic way, you would probably end up doing a procedure and which would increase your practice. So what I'm saying is, it's not going to burn a hole, even though CSO and my healthcare people are the ones who are going to benefit from this. But eventually, this is going to add more value to your practice. And I think it's going to, my practice has increased since the time I got MS39. This is I think it's close to 3 years now. We were one of the first to buy it, and we had a different software. Now we use this beta testing software. Now the software is out open for everybody. Do you agree to this, Dr. Vavekar and Divya? For me, it's increased the practice, not decreased at all.
Yes, basically, lot of patients are getting into the repertoire. So we are able to fit the case somewhere. Previously, we would have blindfoldedly rejected the case.
Pooja, if you go for any other patient where you have an epithelial map, go for an epithelial map. Let's do some epithelial cylinders, Zernica, because this is completely new concept of this. And Dr. Divya and Dr. Chandrasekhar said, you want to see anything you want to show, please let her know, and she would open that particular software, which is your favorite. In fact, it has a big role in cataract surgery also, because it helps to look at when you are healing, and sometimes you put a diopter and half cylinder, sometimes you feel that the cylinders have not functioned. Then you can look at the epithelium and you know which part of the cylinder is actually being taken care and what is actually driven by your corneal epithelium. So no problem. Epithelial mapping has become, and if any one of you are using Schwinn, you can actually feed in the central epithelium thickness and the peripheral epithelial thickness, and that can only possible with the Schwinn machines now, because other machines don't give you that freedom to do it. Okay, I think here again, interesting case, superior stapling, but there is an inferior epithelial hyperplasia, maybe a contact lens wearer. Let's go to the epithelium Zernica. If you can just, wavefront is an interesting here. It's a Zernica. If you can just hold on for a second, let people know, whoever are new to this, it's got an epithelial Zernica, optical quality. cornea. Let's go to just the epithelium. And this is an interesting map here. The one eye, the OS is absolutely normal. There is no, you can see that there is a 5 millimeter zone. You can just put your cursor and say that this is the other eye, where if you go to the 4 millimeter zone here, you can see that a small amount of cylinders have crept in. That means a small amount of 0.5 to 0.30 cylinder is coming directly from your epithelium. In this case, it's not so manifest, but there are times when we had close to a diopter of cylinder from the epithelium itself. And it also gives you the epithelial Zernike maps, which is a complete epithelial Zernike map, which is useful for understanding how good or bad the quality of vision is driven by the epithelium itself. So, you want to say anything? Anybody wants to add anything to it?
You have a case like what Dr. Naren Shetty had shown, where the epithelium was creating, there was a remodeling in the center. The epithelium was somewhat thick and it was throwing a coma. You have any case like that?
Just give me 2 minutes, sir.
I think some of us...
You can keep the discussion on so I can pull out that case.
Yeah.
So, can I ask?
Yeah.
Epithelial remodeling in cataract surgery, is dry eyes the only cause, or what are the other causes?
I feel dry eye is one cause. The second cause is how much time, this is my hypothesis, the time you spend under the microscope. The faster the surgeon, the better. Many times, if you are very slow and you take 45, 35, 40 minutes with the case, when some beginners are doing with your phaco, because of the microscopic light and long time use of, sometimes you keep putting paracaine, because all this changes the ocular surface a lot. And once it changes, you bring in the tsunami. So I feel a combination of these two. But if you want to have a good ocular surface, you have to take care of it post-operatively well. And many times the cataract surgeons just prescribe lubricants and nothing else. You have to take care like how you do for a refractive surgery. You have to look at cyclosporins, look at eye light, EI, or, lot of times we do give that EI stimulation before multifocal surgery, so post 3 months. So you have to have a mindset of a refractive surgeon when you operate a premium cataract surgery. It's not just the lens and fitting your lens perfectly in that space. It's also about how do you take up the ocular surface. Yeah, is this the case, Pooja?
Yes, so if you can see here, sir, Vavika, sir, I'll just show you the 6
Show the
map.
topography also, please. Show the topography
I'll go to
first.
the 6 map. Yes, so Vavika, sir, this is the case I think you were talking about, or a similar case, where you see that there is a little bit of, not little bit, like a lot of inferior epithelial hyperplasia. The center epithelium is around 51 microns, but if you go towards the periphery, it's going to 59 and even 64. So, but your stroma is absolutely normal here. And the wavefront epithelial wavefront analysis shows that the epithelial only it's showing as plus 1.3 with minus 0.5 cylinder. So
that will be 4 millimeter pupil. If the patient has a bigger pupil, it will be much.
If still it is 0.76 and minus 0.36, sir.
Can you increase the pupil to 7? It's not possible. So this is a very important point. Go to 2.
Sir, I will just raise 1 point.
Just go to 2 millimeters. So for everybody here is a very important case, because when the patient is actually reading a small print, he induces only from the epithelium point of view a plus 2.5 diopters with a minus 1 cylinder. So imagine the difficulty for him to read with this power, even though irrespective of putting, you might have, imagine you have put a multifocal on him. I don't know what was put, let's assume he's a multifocal. Then he suddenly goes to dark, or he looks straight, and his pupil is 6 millimeters. Go to 6 millimeters.
This is
now suddenly his vision drops. Imagine these are the cases where patient says that my vision is never constant. Either I see completely blurred or I see completely clear. Sometimes when I see at the distance, my vision is very clear. Every single time we would blame this on a lot of factors other than the epithelium. But sometimes, this case will have to tell us that your change in your pupil size inducing diffractive error change could be driven by just an epithelium. And this is a brilliant case to demonstrate that. Now, Pooja, tell me what you're saying.
So one more point I wanted to ask your suggestion, because see, if you see the epithelial pattern here in the higher order aberration, it is more going towards the keratoconic type of an epithelium. So when your pupil size is larger, though it is not accounting for the refractive error here, but the epithelial profile is like a keratoconic case. So that is also what will impact the quality of vision of the patient. Not the quantity, but the quality. So
Excellent.
Absolutely. For example, you can see that it's a 0.4 diopters of spherical aberration. If you can put it there, it's a 0.4 microns or diopters. I don't know. It's in dioptric, I think. So 0.4 diopters of SA is induced by the epithelial change only. Dr. Vavika, do you want to say anything? Just this brilliance of how the pupil size itself changes the refractive error only from the, I'm sure a lot of this would be negated by the corneal lens and everything, but still there's a quality of vision which is deteriorating because of the epithelial change here.
Yes, a very, very good case. Point number one is that, see, epithelium, the center one is 51 and this periphery is 64. Now 13 microns is quite a lot. Even 4 microns difference on epithelium is significant. Second thing is that this patient, if we put a multifocal, going to be completely unhappy, because when the pupil gets small, he is getting a plus refractive error only because of epithelium, and he's not going to have satisfactory near vision. And at distance, he's got so much keratoconus like aberration pattern, and therefore this patient would have been unhappy solely because of epithelium.
And these patients, what you can do is you can give a trial of the best lubricant to regularize the epithelium, especially when you have this crater, is trehalose. Because trehalose, when you have a very thick epithelium, trehalose is not the great one, because trehalose also has a tendency to swell the epithelium and make it thicker. But when you have this central, like this dip, trehalose works wonderfully well because it creates a increase in the swelling of the epithelium and increase in the uniformity of the epithelium. So if you do put them on trehalose for 3 to 4 months with, say, cyclosporin or one of these medications, when he comes back to you, you will see this cornea being more regular. And we have seen that a lot of these patients, epithelial-related irregularity just disappears. So one take-home point is, when you see this kind of irregularity, the best medication is to look at trehalose, because that is made for, because this is an hypertrophic epithelium, and trehalose work on anything with there is an hypertrophy, anything where there is an autophagy changes. So that is a take-home point for this case. Anything else you want to show on this? I think, Pooja, you have shown both the cases are brilliant. I think everything else has been explained by Dr. Divya. Divya, you have to have anything on this particular thing, because picking up is one thing, managing is the second thing. And, we have to manage this irregularity. And the best way, I believe, is to take care of the ocular surface.
Yes, sir, agreed. I think I also had one case where post-PRK, the patient had irregular epithelium and I consulted with you. So you had advised trehalose, and I saw how it actually changed, and I didn't have the necessity to go back and recorrect the patient or anything. Just with epithelial surface healing, the patient actually improved. The vision improved. Yeah.
Thank you. So I think
one question, sir. The epithelium, do we have any cutoffs as to say, like this epithelium do this kind of procedure or anything like that?
See, when you are
microns, yeah,
when there is a difference in your epithelial from the very center to the periphery of around 10 to 12 microns, you have to be very careful about, and there is meridional change in your epithelial thickness. One meridian is 40, other one is. So I go back and look at the cylindrical component of the epithelium. Up to around 0.5 is expected. You don't have to worry too much about it. But when it becomes more, that will impact your what you're treating. For example, Contura or LASIK, because epithelium is a dynamic one. After you do surgery, it would change again. So you have to be careful about this component factor of this in your planning. And there's no real nomogram for this, but as long as you are aware of it, and I write on my file that epithelial irregularity, that means that I push more for tablet doxycycline if I'm doing a PRK, or I push more for cyclosporins for a longer time period, and I keep steroids for a longer time, because I know these are all epithelium under stress. A simple epithelium without stress will not behave like this. So our protocol would change based on the type of epithelium we see.
Thank you, sir.
I think we have finished most of it. Both the talks were brilliant, and Pooja has shown 2 important cases.